Ladies and gentlemen, a very welcome to this webinar and good afternoon. I want to welcome you to this webinar provided by Patient Line by EUROSPINE. And today we want to address a very specific topic on scoliosis. And we really want to focus on patients and families who are new to this topic and want to know about scoliosis if they have been diagnosed with it the first time. This webinar is taking place during the Scoliosis Awareness Month, and our agenda today will be a short introduction given by myself, and then we have Benny Dahl from Copenhagen with us, who will help us with his talk to understand better the condition of scoliosis, what an idiopathic scoliosis is, what causes it, and what are the first diagnostic steps and risks for progressions. And then we'll also have Fabio Taina from Italy joining us, who will talk about the first steps in the treatment, what conservative treatment options there are, and especially how you can also contribute to the success of the treatment and management of the scoliosis. So our learning objectives today is that we want to help you understand idiopathic scoliosis, what it is and why it develops during growth. We want to learn about the known and suspected causes of idiopathic scoliosis and the factors which could influence the curve progression. We want to discover the first steps of treatments and when they are appropriate. And we want to find out why scoliosis is a manageable condition and learn strategies to cope confidently with the diagnosis and the treatment. First, I want to shortly introduce EUROSPINE to you. EUROSPINE is the Spine Society of Europe. It's a professional non-profit organization focused on the advancement of spine research and treatment. And it's your all-in-one destination for everything around spine. I also want to introduce myself shortly. My name is Peter Förlich. I'm an orthopedic spine surgeon based at the Medical University of Graz in Austria. And as the chair of the Patient Line Committee, I had the honor to organize this webinar today. The Patient Line provides information for patients with spine conditions explained in a clear, reliable, and trustworthy way. It's available in several different languages and can be easily found if you go to the EUROSPINE webpage. I also want to invite you to follow us on social media to get the latest information for everything around the spine. So if you go to the EUROSPINE webpage, just click on Patients, and then you will be right on the Patient Line webpage, where you can find information about different areas of your spine where you might experience pain. You can find different spinal conditions, and of course you will also find the recordings of our webinars. And all of that is available in several different languages. So let me introduce our two speakers today. First, we'll have Benny Dahl with us. It's really a great honor to have him here this afternoon. He's a professor of complex spine surgery in Copenhagen at the spine unit at the Department of Orthopedic Surgery at the Rigshospital and University of Copenhagen. He's a very dedicated and skilled spinal surgeon, but also a researcher and active member of the EUROSPINE, and he's going to be one of our local hosts of this year's annual meeting of the European Spine Society. And then next, we will hear, sorry, I just have to go back to the slides. And then we have Fabio Taina with us. Who is a specialist in physical and rehabilitation medicine. He works at the Italian Scientific Spine Institute, ISICO, in Milan, Italy. He's also very dedicated to patient care, but also into research. He's a member of the SOSORT, where he worked on the guidelines on conservative treatment for scoliosis, and also a member of the European Spine Society. It's also a great honor to have him with us today. I want to invite you to submit any questions you might have by the questions and answers tool throughout the webinar, and we'll try to discuss them by the end of the webinar. And this webinar is going to be recorded, so if you want to review it or share it with your friends, you can find it then on our webpage. So I'll start with a short introduction on the spine. The spine is made of and the intervertebral discs, which act as shock absorbers and allow movement between them. We have 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. If you look at the spine from the front, it should appear straight. And if you look at it from the side, it has a double S-shaped curve. Around the spine, we have strong muscles and ligaments, which are important for the stability, but also especially for the movement of the spine. And within the spinal canal, we have the spinal cord and the nerves running down to the extremities. In cases of scoliosis, the spine is twisted and curves to the side and is often found within the thoracic spine as shown in this example. The spine then appears C or S-shaped. A curve with an angle of more than 10 degrees has been defined as scoliosis. Scoliosis is always a 3-dimensional deformity, and it involves that abnormal curve of the spine to the side, but also rotation of the vertebra. Because of this reason, the ribs are shifted backwards on one side, which leads to the so-called rib hump, which is a typical symptom of scoliosis and helps us to diagnose scoliosis. So if there's a suspicion of scoliosis, patients are asked to bend forward in the so-called Adams test, and then you look at the back of the spine and can easily see the difference in the rib hump on one side. So it's a very sensitive test for scoliosis and helps to recognize it early. In cases where your doctor suspects scoliosis, he might send you to have radiographs of the spine taken to further examine your spine. It is important to recognize scoliosis early, as it can occur and progress during growth, as we'll just hear in a few minutes by Professor Dawn. But when recognized early, it can be treated successfully with a conservative treatment in many cases, and surgery will be required in only a few cases. So that's also what we are focusing on during Scoliosis Awareness Month, that early diagnosis is important to give you the best treatment options and to improve your overall outcome. And with that, I already want to hand over to Professor Benidorm. Thanks again for joining us and giving us some background information about idiopathic scoliosis.
Thank you very much, Peter. I hope you can see my screen.
Yes.
So thank you very much for the introduction, and thank you for inviting me to this important event. As Peter said, I am a professor of spine surgery at the spine unit in Copenhagen, and I owe a big thanks to my colleagues at the team. We are 12 spine surgeons who take care of, among other things, scoliosis patients. And some of these slides I'll present to you have been produced in collaboration with some of my colleagues. So these are the questions I've been tasked to address. First of all, what is in the word idiopathic scoliosis? And also a discussion or a brief talk about the possible causes of scoliosis. How do we diagnose scoliosis? And a lot of this may be a repeat of what Peter already said. And then finally, how do we assess the risk of progression of the scoliosis? I'll do this relatively shortly in the interest of time, because I think the important thing, or one of the most important things with a webinar like this, is to allow time to answer questions from people who are attending. So regarding the possible causes, and these are some of the questions that we very often meet when patients are referred to our clinic with scoliosis. And first of all, it lies in the word idiopathic. That's usually a medical term for when we don't really know the reason for a medical condition, and it's used throughout medicine. So actually it can translate into idiopathic, means the same as we don't know the cause. But very often we have some theories, and we have maybe some data also and some research to demonstrate a relationship between scoliosis and underlying reasons. And since hormones play a big role in growth, and since we see that scoliosis, idiopathic scoliosis, is more often seen in girls than in boys, we know that hormones play a role. And that is combined with the fact that in a lot of cases, scoliosis is diagnosed around the time of growth, the so-called growth spurt. So there's a good reason to believe that the affection of hormones to the spine, and maybe even also to the muscles, may play a role. One question we often get in these patients is it inherited? And we know that scoliosis, in many cases, it doesn't run in the family like genetic diseases, but there is a tendency for scoliosis to occur in some families. And we have done some, or my colleagues in Denmark have done some twin studies, and it's known that identical twins will almost always both develop scoliosis, but the degree of scoliosis and the kind of curve, the type of scoliosis, may be different in identical twins. So that shows us that there are a lot of so-called external factors that may affect whether or not you get scoliosis, but also if you get scoliosis, how it will develop. So these are some of the things that we constantly do research into. So in other words, there's not a blood sample we can take. We cannot do a genetic testing on patients, and we cannot test a pregnant woman to see if she had scoliosis, if her offspring or her child will have scoliosis. So these are some of the possible causes. And what we often tell the patients in our clinic is that we shouldn't blame the young person or the patient or the families. And they will often ask us, did my daughter get scoliosis because she was sitting wrong in the chair, or because she was carrying a backpack, or, all these possible causes? There's no scientific cause for saying that could be the explanation for scoliosis. So we make a big deal out of not blaming the patient or the families for developing scoliosis in a young person. As Peter said, of course we look at the patient, and I'll show you a picture resembling what Peter showed us before, but the final diagnosis of scoliosis is to take an X-ray. And usually when we look at the spine, as you can see on the picture to the right, what you see there is an X-ray of the spine taken from the back of the patient. And the reason we look at the spine and take the X-ray from the back of the patient is to reduce the amount of radiation to the breast tissue, which in female persons is a concern that we have to think about. And what we use is the so-called cup angle, meaning that we put a line in the two vertebral bodies that is mostly tilted and measure the angle. A couple of things are important when we talk about the cup angle. First of all, Peter said that most spines, or the spine, is a straight line when you look at it from behind. Actually, very often there are small curvatures up to around 10 degrees, and as Peter said, when it's more than 10 degrees, it's defined as scoliosis. But some patients may think, or families may think, that the spine has to be a completely straight line. But if you have a curvature up to 8 degrees or around 8 degrees, it's not a scoliosis. The other important thing to stress is that there's a relatively high degree of variation when we do these measurements. This means that it doesn't really make sense to say that you have a scoliosis of 15.235 degrees, because if Peter measures a scoliosis and I measure the same X-rays, we may have a difference of 3 to 5 degrees in what measurement we have because of the way we put in our lines. So what we usually tell the patient and the families is that they have a curvature or scoliosis degree of around 15 degrees. So it's not like a blood sample with the number, 15.265. It doesn't make sense. This also means that to detect an increase in the curvature, it doesn't make sense to take x-rays very, every month or something like that, because there has to be a certain degree of change before it gets bigger than the variation of the measurement. So I think that's an important point. One thing about scoliosis, and that's what I've tried to illustrate here, is that what is the possible danger of scoliosis? Well, the reason we want to detect scoliosis early on and initiate treatment in the relevant patients is that as you get older, if the curvature, especially in the breast part of the spine, if that increases, you can have affection of your lung function. That's typically what we want to avoid. But also we want to avoid that the patient develops long-term back pain. That's another consideration. This is a tool that we use in Copenhagen to analyze the degree of scoliosis. And the reason I bring it here is, as Peter said, that scoliosis is a three-dimensional condition of the spine. And as you can see on the three pictures to the right, you can see the spine. We've rotated the spine, and I hope you can get an impression about the rotation of the individual vertebral bodies. And typically in the upper part of the spine, in the breast part, because the ribs are attached to the vertebral bodies, if the vertebral bodies, if they are rotated, the ribs will typically be elevated on one side compared to the other side. And that's what we call the rib prominence, and that's what we see clinically in the patient. And that's what we look for when we do our initial examination. And this is what it looks like in a patient with a typical scoliosis of the upper part of the spine. As you see to your left, you can see, of course, the back of the patient. And what you can notice is that already at the shoulders, there's a slight asymmetry. And you can see that the spine is curved a little towards the right. And when you look down into in the hip part of the patient, there's a little asymmetry. That's one thing we look for. Also, you may get an impression that the shoulder blade on the right side is a little more prominent than on the left side. We look at the skin and see what it looks like. And then on your right side, you can see that the patient is bending forward, and you can see the rib prominence on the right side. And that's because of the rotation of the spine. So that illustrates the three-dimensional aspect of the scoliosis. This is a test that in some countries is used for so-called school screening, where children around the growth spurt are called in and are examined clinically with the Adams test, where you bend forward. So this is an essential clinical examination, and actually the clinical diagnosis is made based on this examination. Probably around 3 to 4% of the population has a degree of scoliosis. Of course, we don't see all patients, but that's a reasonable estimate. And as you can see, it's much more predominant in the females compared to males when we talk about the adolescent idiopathic scoliosis. And what is important here to stress is that we think about adolescent scoliosis as an increased curvature of the spine in an otherwise healthy individual with an otherwise healthy spine. For the smaller curves, the ratio between girls and boys is much more equal. And also, if scoliosis is seen in a younger individual under the age of 10, there's also this ratio between girls and boys is much less pronounced. And important information to patients when they're diagnosed and their family when they're diagnosed with scoliosis is that it's not unusual that it's an accidental finding. In a typical girl, what will happen as they approach pre-puberty is that the family or the parents won't see the patient without clothes on as much as they used to when they were younger. And all of a sudden, they go on a summer vacation and they see their child in a bathing suit, and they will notice this asymmetry of the spine. That's a typical situation. And a lot of families will say, how come we saw it this summer when last summer there was no asymmetry of the spine? And that's typically because the patient has gone into the growth spurt, and that's when you see the growth of the scoliosis. So what is the risk of what we call progression? In other words, what's the risk that a scoliosis, once diagnosed, will increase to a degree where you will need treatment, either with a brace, which we'll hear about later, or at some point surgery, which is done in a relatively low number of patients who have diagnosed scoliosis. So the key point here is to say that what we use to estimate the risk of progression or increased curvature is the remaining growth of the patient. And of course, in girls, we can use the time of the first period, but we can also take some x-rays of the hip and the so-called iliac crests, as you see on your left, where you can estimate how much growth is left. Probably more precise is an x-ray of the hand, where you can estimate the remaining growth. And that will decide in a curvature whether or not you should treat and how long you should treat the patient. So a couple of take-home messages are important, I think. First of all, and this relates to our strategy in Copenhagen, what we try to tell the families and the patients with scoliosis is that they should try to lead a normal life. They should not consider themselves sick with a chronic disease, like if they had diabetes or something else. Lead a normal life. We also say, don't Google this too much, because people will see all kinds of other diseases that lead with scoliosis, and maybe they will get concerned. We have done studies regarding the occupation and education of patients with scoliosis. And if it's treated correctly in the cases where you do need to treat it, the vast majority of patients with scoliosis will have a normal life, even if they end up with having surgery. And finally, a question that we hear from a lot of families is, what about pregnancy? Can I get pregnant? What about when I have to deliver a baby? Do I have to have a cesarean section? And basically, what we can say is that you can have a normal pregnancy. The scoliosis will not affect the mechanism of delivery. In some cases, you may have a little increased risk of back pain during your pregnancy, but pregnancy should not be avoided if you have scoliosis. So we try to say to the families that they shouldn't treat their child or a young person and protect the patient from having physical activity and be active. And I think that's a big part of the education in adolescent idiopathic scoliosis, is not to try to give the patient an early identity of a chronic patient. That's something we stress at our clinic. So with that, I hope you got an impression about our take on AIS, and I look forward to answer your questions. Thank you very much, Peter.
Thanks a lot, Benny, for that great talk. We have already some questions online. I would suggest that we have next a talk by Fabio, and then in the end of the webinar, we'll discuss any questions. So please feel free, if you have some questions coming up during the talks, just type them in. We won't forget about them. We will discuss them in the end. And I already introduced Fabio at the beginning shortly. It's really a great honor to have him here, as he has really a great experience also in scoliosis, the conservative treatment, as I also mentioned. He works at different societies, and it's really great to have you with us, Fabio. And I think you're just ready to go.
Thank you very much, Peter, and congratulations to Benny for this great overview of the problem. And I'm here today to tell you a little bit more about the treatment options, especially about the rehabilitation, the potential rehabilitation for this issue. And if I can change my slide. Yes. Okay. So we will speak about the different options, when to observe, when to start the treatment, the exercises, those specific for scoliosis, bracing. There's a lot to say about bracing. There's a lot of myths and legends, and there's a lot of truth also. What about the limits of our conservative treatment, and what about how to support the emotions and the feelings and the life and the growth of these young patients that need to grow and need to do their treatment in the meantime. So we have guidelines, fortunately, for scoliosis. We have a piece of science to give us indications, and then we try to apply what we know from science in the best way for every single patient. The guidelines are based on the research and the publication coming from all around the world, and so this is a strong base to discuss our options and decisions with families and patients. And there are some goals set from these international guidelines. There are some general, these are guidelines for rehabilitation, so not surgical guidelines. And you will see here that one of the main goals is to try to avoid surgery. That means to try to avoid to have a too big curve that could benefit from a surgical procedure, to improve aesthetics and take care of the quality of life, and reduce pain and disability when it's there, so especially during adulthood. Then there are some goals that are set based on the Cobb angle, so the radiography, which is a surrogate outcome that can predict, as Benny told us, about the progression, about the quality of life. So we use this tool with all its limits, because scoliosis is three-dimensional, because it's helpful and because a lot of literature is based on these parameters, so we cannot do without that. But the decisions are not just made on the X-rays and on the Cobb angle, and this is very important to be said. And the guidelines, considering the age, the Cobb angle, and the general situation of the patients, give a wide range of indications, and here is the base for our approach to patients. We know that the scoliosis is a wide variety of different degrees of severity. There are very mild, moderate, severe scoliosis. And the approach is not the same in all these cases. We have to guarantee the best approach considering the short-term risks and the long-term risks. So during growth, we know that there is a progression usually, sometimes very fast, sometimes less. Some scoliosis by themselves stop at a low level, others progress a lot despite the treatment. So we need to take care of these. And so the different approaches, ranging from observation, exercises, soft braces, hard braces, and surgery, need to consider the short-term and the long-term risk of the patients. And then, of course, is the discussion with the patients and the family that speaks the final word about what to do. Paolo Sibilla was a master of scoliosis in Italy and was a sort of founding father of our institute. And he used to say that for a big sample of young patients that need to be observed because they have some asymmetries and that become a real scoliosis or are already a scoliosis but very, very small, there's a wide variety of people needing observation. A few of them will need exercises, even less bracing, and just a few surgery. So this should be the approach. It doesn't mean that everyone needs to go through all the phases, but it means that for every patient, we need to choose the right treatment according to all the factors that leads to progression and determine the risks. Observation is done when there are some asymmetries of the trunk, when there is a prominence, when there is a small curve below 10 degrees, when there is a residual growth, when we feel it's not needed to have a treatment, but there's something, so maybe there will be an evolution. So we take care of this with observation. The following step are the exercises. Exercises should be based on a movement which is called active cell correction, which is a three-dimensional realignment of the spine that every patient should learn. This is specific for the curve pattern and for the for the feature of each single patient, his skills, abilities. Not everybody can do the same, and sometimes the active self-correction can be really challenging. Exercises apply to curves larger than 15 degrees, plus minus 5, because as Benny was telling us, there is this measurement error. So don't consider, the sharp number. There is the measurement error. Always consider this when you judge your results. They can be done and should be done when we have only as a standalone treatment, during bracing weaning. There are limits for the application of exercises. When you have a curve exceeding 25 degrees and still a fast growth, exercises are not enough. And about the active self-correction, you can have an idea of what it can be done, how it should be performed in this patient. You see the X-rays and you see the movement of the girl trying to realign the spine. So based on this position, on this realigned position, patients will perform exercises to try to stabilize, work on the core stability, and improve the strength and the reflexes of the spine. Then, when exercises are not enough, when curves are larger than 25 degrees, it depends also on the phase of the growth and so on. It's not just the Cobb angle that determines the prescription. We can start with the brace. And for the brace, we know that it's very important, the dosage. The higher the dosage, the higher the probability to get the results. Being these avoiding progression over a severe threshold of 15 degrees or having an improvement or whatever we need. And recent evidence tell us that when we go very high with the dosage, up to 22, 23 hours per day, we can have really better results than when we have just 18 hours per day. The protocol usually applied for bracing that must be custom-made based on the single needs of each single patient is based on a high dosage beginning with 21 to 23 hours per day. Some cases can benefit just from 18 hours. Then there should be a progressive weaning according to the results, both clinical and radiographic. It's important not to go too low before we reach an average maturity. Usually we say research 3, which is, almost at the end of the highest and the fastest push. We should brace until we reach the end of the growth, which is set at research 5. During the whole process, we should perform exercises. And it's important to notice that we shouldn't brace smaller curves below 15 degrees, but the indication starts for curves larger than 20 degrees. So just to show you a couple of examples of what can be done with bracing, we have quite severe curves, 58 degrees, right thoracic curve with quite evident imbalance to the right of the trunk and the prominence. The girl wanted to try a brace to see if she can achieve good results. And with this brace, she had a good realignment of the spine, both in the frontal and in the sagittal plane. She did her treatment, changing the braces and growing up with the brace. And at the end of treatment, you can see on the right the beautiful improvements that she had about the physical appearance and the symmetries, but also the X-rays improvements. So she gained really better spine, much more balance. And so this was a great achievement for her since she went through her growth. And also the sagittal profile, as we know, it's important to give a good balance. And the brace must respect this and try to take care also this aspect, not just the coronal plane. It's more a three-dimensional correction. And another even more shocking case was this one with this girl with a very, very big asymmetry, big prominence. You can see here the asymmetry, the hump, a really severe curve. She wanted to avoid surgery, at least for the moment, so she started a brace treatment. And with this brace, over time, she had a good embrace correction. She was very consistent with the brace, and she get really incredible results in terms of aesthetics, but also in terms of progressively reducing the curve, ending up with these aesthetics after a few years and this curve at the end of treatment that was stable after a couple of years after winning the brace. How can we reach these results? We need to be very consistent, having good braces, but having also very committed patients. And sometimes those with the more severe curves are more committed than others with less severe. We are using tools to support patients in the journey, and this is a temperature sensor called ThermoBrace that helps us to monitor and discuss with our patients what's going on, how they manage their brace and the treatment. And this is very useful because it's an objective way to understand what's going on. Bracing is not perfect. It cannot change the natural history of every single scoliosis. A review of different studies reporting data on surgical curves ranging from 40 to 60 degrees on average show that it was possible to have improvement in 32% of patients, stabilization in 26, still worsening 42% of the sample. In the different studies, the success rates are quite different. So this means that there is the possibility to try a brace, even if more severe curves, but not every time we can be successful. So this is an option that can be and should be discussed, and then based on the wish and the desire of the patients can be tried, and then otherwise there's a surgical option that can be explored. Because the best way to approach health and pathology today is the evidence-based clinical practice that put together the best science, the best clinical expertise, but also the patient's value. And so informing the patient and sharing the decision, we can have the best option for every single case. So the decision is not just on the side of the physicians, it's a lot on the side of the patients. And this is important. And the shared decision-making is today really part of the process. So what we should do is always seek our patients' participations, help, explore and compare treatment options, assess the values and the preferences of our patients, have a shared decision, and evaluate the decision with our patient. And basically, this is even more important with scoliosis rehabilitation because this is a team approach. And in the team, there is the physician, the physiotherapist, the orthotist, the orthopedic surgeon, the psychologist sometimes, and the expert in motor science. So a big team together with the family to go through this very difficult journey. But it's possible with all this team, with all this support to have good results. And there are some other tools that can help, and we can try also to have some fun about these. For example, we have a contest for several years in our institute. It's called Concorsetto. It's a joke putting together like a contest and brace. In Italian, the word is very similar. And so you can see here the products of our patients who started shooting photos showing how they can hide their brace, how they can live happily with a brace. This is another girl suggesting how to dress with a brace, not just with big clothes. You don't need that if the brace is done in a certain way. You can move much more than you expect, and that's very important. So try to live a normal life. You can live a normal life as much as possible. And then again, try to be, funny and try to enjoy your life and treat your spine while you grow up and you have also a normal life, not just thinking about your treatment every day and every moment. And some achievement that can be helpful are things like this. Now we allow our patients also to go and swim with a brace. And so this is a young kid swimming in the sea, in the beautiful Italian sea with a brace. So I think these are things that can help, and these tools and these pictures and videos can help really young patients to understand that they can do much more than they can expect also with a brace. So to conclude, we can improve the scoliosis even if we cannot improve all the scoliosis. there always a certain rate of failures. In our institute is about 3%, and it's low, but 3% needs something else, something we cannot provide, and not always we can improve enough. So it depends also on the starting point, the best option. So going back to the Sibylla theory, you need to choose the right treatment for yourself, considering also where is your starting point. But you can live a normal life while you treat your spine, whatever you're doing. As Benny was saying, even after surgery, you can live a normal life. So just go for the best option for you. Discuss with your doctors the options and really reach a shared decision, and then go straight. And remember, you are not alone. There's a team working with you. You have your family. There's a team, experts, and everybody's working for your wealth and benefit. So thank you very much, and happy to join the rest of the panel for questions.
Thanks a lot, Fabio. It's really a great and motivating talk. It really shows that it's not only different medical professions working together, but it's really the patients working together with the doctors and the physiotherapists and the family, and we need all that support from all the sides. And if that works well, then you can have really a normal life, even though having scoliosis. We had some questions, and I'm just going to summarize them and discuss them with you. One of the first was on the diagnosis, and maybe Benny, you can answer that. How is it possible to differentiate between the different types of scoliosis, like congenital, neuromuscular scoliosis, and how do you know it is an idiopathic scoliosis after all?
Yeah, that's an interesting question. So I would say that as soon as the scoliosis, we have some, not red flags, but we have some suspicions that it may be not idiopathic, but something different than an idiopathic. So if a scoliosis is seen in a child younger than 10 years of age, it increases the risk that there's an underlying comorbidity or something, that could explain the scoliosis. So younger children, as soon as they're younger than 10 years of age. Also, if we do an examination and there are what we call abnormal reflexes, some neurological signs. But I would really say that young age, and if it's not a girl, that's some of the signs that it may not be an idiopathic scoliosis. And of course, if we have a child with a syndrome who is born with some kind of syndrome or a neuromuscular condition, as soon as that's the case, we classify it as what we call a neuromuscular scoliosis. So basically, to qualify, so to speak, for a diagnosis of idiopathic scoliosis, you have to have no significant comorbidity. When we look at the question about congenital, what we mean with the word congenital is that the scoliosis is caused by an abnormal formation of one or more of the vertebral bodies when you are born, basically. And that's what we can see on the X-ray typically. So what I used to say to the patient is that 50% of patients or more with scoliosis are idiopathic. The rest of patients, they have an underlying condition.
So the age important, and if it has been otherwise healthy girl before, and then age, at some point, as you mentioned, you see the shoulder asymmetry, so then you can suspect it to be or diagnose it as a idiopathic scoliosis.
Exactly.
Right?
Yeah. And we can also see it on the X-ray. So the idiopathic scoliosis, they typically have, we can classify them on the X-ray. And if it's, for example, a neuromuscular scoliosis, instead of having this S shape as we talked about, some of them will have more of a C shape, showing the entire spine. So we can see it on the X-ray as well.
Okay. Yeah. So your doctor can help you and explain what type of scoliosis is and can really diagnose that well. The next question was on the clinical examinations. Both of us mentioned the forward bend test, and you get quite some information about the forward bend test. Why is it still necessary to do X-rays at some points? At what points do we do X-rays? Why don't we do it? So it's like also the radiation exposure.
Yes, I saw that question. It's highly relevant because, of course, when we think about X-rays and radiation, we think about the risk of later developing cancer and things like that. So, first of all, the first time we see the patient, it's based on an X-ray. Typically, we have one X-ray, and our strategy in Copenhagen is to say that we at least need one more X-ray after a period of time. It can be 6 months, it can be 9 months, depending on the age of the patient and the first period. But at least have 2 X-rays with at least 6 to 9 months in between to assess the risk of progression. But in older patients, we've been more, we think more about informing the patient. So saying that there are no signs of increase over these 2 X-rays. So we instruct the patient. And I think Fabio's point about shared decision and involving the patient, we make a big point out of explaining to the parents and the families what we look for. So we can say, now there's very, very low risk of progression. We don't need to follow you anymore, but you have to look for these signs, and then you're welcome to be referred again. I think that's an important point. So we don't necessarily do repeat X-rays, every 6 months in all patients.
Okay. I guess Fabio, same for patients during conservative treatment. You also limit the radiographs when you have a brace.
Yes. So let's say that on average, we do an X-ray every year when we are under treatment. And for smaller curves, we just use the clinical evaluation. So the clinical evaluation is already enough to understand if there is a change. In case there is a change, you can ask eventually for an X-ray. There are some new technologies today, like the ultrasound. There are just a few of these machines around the world today. It's something that can be used. We have one in one of our facilities, not in every of our facilities in Italy. It can help to understand if there is some kind of progression that needs a further evaluation with X-ray. That's how we use it now, not just rely on that. We think we are not ready for that, but it's a further tool. Then there are low dose X-rays that are becoming more popular. There is this EOS system. It's not available everywhere, but it's becoming more popular, and I know that many experts recommend this. So there are options. And anyway, the new machines are much safer than in the past. So the risk, as Benny was saying, the risk of cancer today is really very, very low compared to the past, where the machines were very aggressive, and it's totally different now.
It's understandable that families and patients are afraid or are concerned about that risk, but I think we can reassure that doctors are really taking this risk serious and trying to reduce exposure as much as possible and still give you the best treatment and management of your scoliosis. Another question was about the risk of spinal degeneration with patients with scoliosis. What do they need to expect in the longer term? Are there a high risk of like degeneration, disc herniation, or etc.? Maybe Fabio can answer.
Fabio, yeah, you can answer that, Fabio.
Okay, so well, degeneration is part of life. We lose our hair, the hair becomes white. We change outside, we change also inside. So some degree of degeneration is normal, even in those patients who are not patients who have a straight spine. So there are degenerative scoliosis that occur later in the life in the elderly. And then, yes, there is a risk of degeneration and progression of the curve, which is more relevant, in my opinion, than the degeneration of disc and this kind of stuff when you already have a curve. So it's more about the reduction of the balance of the spine that can occur over time than the degeneration of the single levels. So I would look more about the global balance of the spine than the single levels. when we have an idiopathic scoliosis in young patients that become an adult and then an older person. I don't know what Benny would suggest about that.
I agree, but I think it's very important to distinguish between a couple of things. First of all, if you have your scoliosis in the lower part of the spine, what we call the lumbar part of the spine, there's most likely a little higher risk of scoliosis-related degeneration compared to the curvature in the upper part of the spine. And also, the patients who have surgery, and I can see there's a question about if you do surgery, how long do you fuse the spine? How long do you stiffen the spine? That's a big consideration when we do surgery, because we want to find kind of a sweet spot between correcting and stopping the scoliosis, but not stiffening the entire spine down to the pelvis. But as long as most likely, if you leave 3 levels mobile in the lumbar spine, there's not a high risk of increased risk of degeneration. But there's a lot of things we don't know. And one thing is important here is that there's been a lot of research in scoliosis, but what we still need is long-term studies where we follow up on patients who have had non-surgical treatment or surgical treatment or observation 40 years after surgery. And that's what we really need, good, high-quality, long-term studies. That's what's needed to answer a lot of these questions.
Yeah, if I can add something, it's one of the challenges is also that the techniques and the tools we use are changing. So now we have the follow-up of the techniques that we had 40 years ago, and both braces and surgery changed totally. So it's always challenging, but it's absolutely correct what Ben is saying, that we need long-term follow-up for every tool we are using.
So Benny was on the focusing also on the next question we have. Surgery is a whole complex topic again, and we could talk a lot about it. Maybe you can answer just shortly, why does it make sense actually to have surgery at all? Although when do we do surgery, and why is it better to have a straight fixed spine than a curved flexible spine? How could you explain that to the patient?
So again, we have to distinguish between 2 primary curve patterns. One is the curve in the upper part of the spine, in the breast part of the spine. And the indication, as we say, for surgery is when you have a scoliosis, when you approach 50, 55 degrees, something like around that area, that's when we have a good indication that if you don't treat it surgically, there's an increased risk that you'll develop problems later in life. That could be pulmonary problems, that could be pain. And our information to the patient is that it's relatively low risk to do surgery in a younger individual, 16 years of age, for instance, compared to wait and see and then trying to do spine surgery when you're 40 or 50 years old. And the spine is more flexible when you're younger, so there's a bigger risk that you can correct the spine to a normal shape. That's one consideration. In the lumbar spine, it's a little more, and also I'll say that the surgical techniques, as Fabio says, I mean, it's a few number of patients who actually have to have surgery for scoliosis. But the important thing is to say that our surgical technique has improved a lot over the last 30 years. We have very good implants. We have very good monitoring of the patients during surgery. So the risk of a severe surgical complication is relatively low, but of course you have to take that into consideration as well. In the lumbar spine, it's a little more challenging because we don't want to fuse the spine, and that's where we try different surgical techniques, where instead of doing the surgery from the back of the spine, sometimes we do it on the front or on the side of the spine to leave more levels mobile. So those are, I think that's some of the considerations you have to talk about with the patients.
That's going to be a very individual decision, also discussion with the patient to explain for the certain kind of scoliosis they have, what we can offer, how it can be treated, and that's really something we have to discuss also in detail, I think.
Exactly.
You can say if surgery is needed, then we also have a great chance to help patients on the longer term also.
Exactly.
And that's the last question I think we are going to answer. It's does a patient after adolescence, or if it transitions into adulthood, the spine does not grow anymore? What does he have to expect on the long term? And what are your recommendations for the ongoing care? Do they need follow-ups every year, or do they need treatment? What should they do on the long term?
So we published a number of studies where we've done 40 years follow-up of patients who had brace treatment of scoliosis. And as Fabio said, brace treatment has changed. But when I was a young spine surgeon, I was told that when you're 18 years of age, the curvature you have will never change. You don't have to think about it anymore. We've modified that information just a little bit by saying that live a normal life, don't think that you're chronically ill. However, you had scoliosis as a teenager. So as you get older, if you develop back pain or have a feeling that your spine is getting more curved, just have it in the back of your mind that maybe you should get a checkup sooner than if you didn't have scoliosis. But again, I think it's a very delicate balance between not making the patient a chronic patient for life. But we've modified our information just a little bit based on these studies, but not regular follow-up with X-ray every 5 years, for instance. I don't think there's any science to support that strategy.
Fabio, can you maybe give some recommendations on the activities, or what patients should do? Should they do physiotherapy? What should they do in their further life?
Fabio?
Yeah, no, we have a different protocol for that. We do regular follow-up to see what's going on, and we, in case there's a progression, we try to act before it becomes a too big curve. Usually, we recommend just a lot of physical activity to try to apply the principle that they've learned during the exercises. And a very important thing is that they have to be confident with the spine and think that they can bear weights, they can have a normal life, they can act, they can move, they can do everything. So I agree on this point raised by Benny. They are healthy, they need to do everything. Then we recommend a control, like when you test the blood pressure and you have like your blood test once in a while. So that's the only difference. But I don't want patients to be under treatment for their whole life. Absolutely not.
I think that's a very important message, and that's also what the Scoliosis Awareness Month should be about, that you can live a normal life with scoliosis. It's not a chronic disease. It's a condition you have. It might accompany you during lifetime, but it's not a chronic disease, and it's really important to stay active, to stay motivated, to do physical activity, to do sports, and you really should do that and try to live a normal life as good as possible. And just to wrap up the beginning again and go back to the diagnosis, during adolescence, as we saw, we have treatment options where we can potentially lower the risk of needing surgery to give you a best outcome for your further life. So it's important to recognize scoliosis and really the working together of doctors, patients, and family to keep a good management during adolescence and to help you to live a good life after all this. I think what we really can achieve and should work well. So I think we are just finished the hour we had planned for the webinar, and I just want to thank you again, all the attendees, for joining us. If you want to share that webinar, it will be online on our Patient Line webpage. So we invite you to visit that webpage, also our YouTube channel, where you can find more information also on scoliosis and different spinal conditions. And of course, a very great thanks to Benny and Fabio for giving these great and motivating talks today. It's really great to have you with us, and thanks a lot for joining us.
Thank you. Have a nice weekend.
Thank you. Goodbye. See you.
Goodbye.